Good morning. So welcome to second part of basal ganglia. And plus today we'll be talking in reasonable detail about the Parkinson's disease because that is the practical implementation of what we learnt in basal ganglia. Plus we'll be watching the images of diagnostic images of MRI. And that there is diagnostic images of Parkinson's disease, that is typically we'll see the MRI images. Plus we'll be talking about the DAT scan, etc. Because they are something which is so typical, and as such there is nothing like any lab test, right? So that's why these tests, they play a very major role. So let's start. Okay, yeah. So what we now do is say basal ganglia, right? So we last time we talked in detail about the basal ganglia. So it was like that caudate nucleus, right? This was caudate. Then this was that nucleus accumbens, right? Nucleus accumbens. Then over here it was that amygdaloid body, right? Amygdaloid body. And then there was over here the putamen, right? Putamen. So caudate and putamen collectively call as the striatum, and this striatum is important because say it was playing major role into various loops, right? And then on the medial side there was globus pallidus. Globus pallidus was having two parts. One was medial, one was lateral. Medial was medial part, that was interior. Lateral part was exterior. So we called them GPE. That means it is external, and GPI is the internal. Both of them will be dealt into our that loops, right? And then there was thalamus, then substantia nigra, right? And then subthalamic nucleus, all of those things, right? Subthalamic nucleus, then substantia nigra. Just remember it was into substantia nigra was into midbrain, right? It was into midbrain. Today you'll be learning one more character into this midbrain, that is the red nucleus, right? Because it has got also some important role into the motor coordination, especially when we'll be watching it from the MRI perspective. The things which you'll be learning today, at times you might feel like that it's not like a radiology exam, but once you will watch it, once you will understand it, right, you will enjoy it. So very basic images I have put, very easy to understand, but at least one thing is sure, that you will definitely be able to understand the anatomy part very well, right? This circuit, that is very important, that was like basal ganglia, and that basal ganglia will be feeding to thalamus, right? And this thalamus will be talking to cortex, right? That's the circuit which we need to know. Okay, now here comes those loops, right? Whenever we talk about, last time also we talked about those loops. So today we'll be going at a reasonably high speed about those loops, so that we can focus on that oculomotor loop and the limbic loop, which were not discussed in detail last time, right? So there was one was the motor loop. Motor loop was for simply known movements, things which we already know, things which has already been learned. There were two paths, right? One was the direct path. Direct path was stimulatory. Then the indirect path, right? Indirect path was inhibitory. So that is when the action is to be stopped. Inhibitory path, action is to be initiated, is to be executed. The direct path, when we want to learn something, right? So it was called as the learning path. We'll talk about it, right? Because when you learn something, the feeds has to come from various areas. So this is the learning loop, right? Then the limbic loop. Limbic loop, simple emotions, right? So why? why it is like this when we are not in good mood, why it is like when we are in good mood, why it is like this is like that, right? All those emotions, because face represents a big area. And then we'll be talking about oculomotor loop, right? Very interesting, right? We'll come to that. Basically, oculomotor, as the name suggests, right, it is related to our vision. So basically it is gaze. Gaze means when you watch, right, steadily you watch. We watch it in different styles, right? Sometimes we watch very rapidly, sometimes we go very smoothly. All those various types of movements, right? Vergence movement, etc. So we'll talk about it. Gaze and the eye movement. So that's like a brain map. This is what we'll be discussing. And on top of it, once this is complete, we'll be talking about Parkinson's, right? Now, in Parkinson's, not only that we'll be telling that, okay, it is the neurodegenerative disorder of substantia nigra and done, bye bye. No, we'll actually watch the symptoms. We'll try to correlate those symptoms with the loops, right? We'll watch the diagnostic part, that what exactly is the absent swallowtail, what exactly is swallow, why tails looks like that, right? What is the weighted this image, what really happens when we see that image. So I've got the normal as well as the abnormal images, right, in which in one case, or when there is a unilateral sign, so that you can always compare it. Plus we'll also be talking something about the treatment part, right, because this will enhance your pharmacology. Not at all difficult to understand, because we know this concept very well, that whenever, basically it is a game of dopamine, right? It is a game of dopamine. So when new substantia nigra, right, to be specific, that compacta, when the substantia nigra is affected, right, what will happen? That dopamine is gone. If the dopamine is gone, in the treatment, what you give? Artificial dopamine, right? So you give that artificial dopamine. Second, you try to produce more dopamine, right? You produce more dopamine. Then third, you prevent the breakdown of dopamine, right? So that it should be acting, whatever the dopamine which is available, it should act for a longer time. But these are the principles. Plus there are few drugs which are symptomatic, right? They are symptomatic, so that patient is comfortable. When nothing works, if this is the medical part, when this thing fails, you need to go for the surgical part, right? And in surgical part there is deep brain stimulation, etc., right? That's what we'll see, because in that, actually the probes are to be inserted into the skull. So it is an exploratory thing where things are to be inserted, surgical. So that is only when the medicine or the medical treatment is refractory. Refractory means it is not effective. Only then the say DBS, that is the deep brain stimulation, it comes into picture, right? Till that point, not. So this is like high speed. I just told you that what exactly we shall be discussing. Let's start with, so we know what all those basal ganglia are, right? So first we start with a very quick understanding of motor loop. And in motor loop, it is the direct one, direct pathway, right? The direct pathway. Parallelly, right now we'll keep on talking about that, what exactly happens into Parkinson's, right? Because we'll be knowing exactly that, yes, this is what really happens. So in this, stimulatory and inhibitory neurotransmitters will be working. Stimulatory would be glutamate. That's right, right? Glutamate. And inhibitory will be GABA, right? Gamma aminobutyric acid. GABA. GABA. So game starts always, right, with the motor cortex, right? This motor cortex will always send a stimulatory thing to this striatum. Now, to this striatum is like our friend, right? We know that it is the combination of caudate and putamen. When we'll be learning, say, DAT scan, right? In DAT scan, you will see that why this knowledge is important, because you will be thrilled to know that yes, this is the reason why this comma shape appearance goes away and it becomes oval, right? So it is based on the principle of that pickup of transporters, dopamine transporters. Let it come. So motor cortex to striatum, so this striatum is caudate plus putamen, right? Then it would act on what? This is the direct pathway, right? So it will be acting on GP internal and the substantia nigra reticulosa, right? Now both of them, they will be acting on thalamus. This is the circuit, right? Right now we have, and then this thalamus will be acting on the motor cortex. Now what really happens, that both this GP internal and substantia nigra reticulosa, right? They always say that, array, don't work, right? Don't work. When they are active, right? That means when they are releasing the neurotransmitters, they are telling thalamus not to work, right? So they will tell the thalamus not to work. Striatum, what it would be doing, striatum in this case, what would be doing? It would be inhibiting GP internal and substantia nigra reticulosa. It will be inhibiting both of them. When they are inhibited, that means now our thalamus is released, thalamus is free, thalamus is happy, right? And thalamus will start sending the positive neurotransmitter and the muscle contraction occurs. So basically direct is for movement. Let's walk, right? Last time's our motive was let's work. So let's work is the phrase for direct pathway. In this we add something extra, right? And that extra is to be added on onto the onto the striatum, right? And that is substantia nigra compacta. Now this is something which uses dopamine, right? Dopamine as the neurotransmitter, right? Dopamine is same. Are there risk? Let it come, boss. Let it come, right? First, let's finish this. Okay. So substantia nigra. So I'm talking about deep brain stimulation, right? Let it come. Any surgery always carries some risk, and this is especially the brain. Okay? So substantia nigra compacta, right? So that is where the dopamine is released. But it is like D1 and D2. There are two types of dopamine receptors. So this is where the D1 is used. D1 is stimulatory, right? It is the same dopamine. When it will be acting on D2, that is inhibitory. So over here, this is stimulatory, right? Because the principle of direct pathway is, yes, we want to work. So this will be stimulatory. What this will do, what this dopamine will do, this is like a super fine control, right? This is like a super fine control. So if this control is lost, so then rest of things, they go for the crude way, right? I think on Saturday or Sunday I saw a movie, right? I saw a movie, so I'll talk about it, right? In that there was one character, he was constantly doing this is what is called as the pill rolling movement. This is classical for Parkinson's, right? Especially when the substantia nigra is damaged, and the frequency is 5 hertz. So if you really calculate, right, so it is like in 1 second, usually it is 3 to 5 times, right? They roll it like this, as if there is a pill over there. Very classical sign which was shown in that movie. The movie was about the escape room, right? The name of the movie is Cube, and in which people were trapped and they were supposed to escape from it. So one of the character was having this, right? Typical pill rolling movement. So I wrote it in my diary and thought of that when we'll be talking about this particular Parkinson's, we'll talk about it. Okay, so this is the direct pathway, right? So where the dopamine comes into picture. Now, when we talk about indirect pathway, right? This is indirect. So we are talking about motor loop, right? So this is the indirect path. In indirect path, again, cortex is there. Cortex will always be talking to striatum. Striatum, you know, it is caudate plus putamen, right? And this caudate, this time, okay, let's write both of them. GP external, GP internal. Okay, right? Over here, we have got two more characters. One, substantia nigra, right? Substantia nigra was already there. So this substantia nigra is reticulosa, right? Because that works on the GABA. Substantia nigra compacta, right? That will also be acting. Yes, we talked about it, and that will be acting on striatum, right? This GP externus, this brings one character, and that is subthalamic nucleus. So this subthalamic nucleus is acting on substantia nigra and GPI. They both of them, they are acting on thalamus, right? And thalamus on cortex. So this substantia nigra now it is, because this is indirect pathway, right? So it's not talking directly to GPI and the substantia nigra reticulosa as compared to over here when GP internus and substantia nigra, they were directly told or acted by the striatum, right? So this time things are going via GPE. So that's why this is like indirect path, right? Indirect path. Okay. First, let's understand what they do. By default, right? Normally, GPE. So this is normal, right? Normally, GPE tells this STN, right? This is substantia, this is subthalamic nucleus. So STN, subthalamic nucleus, right? So GPE normally tells subthalamic nucleus that you don't work, right? It's telling you don't work. What subthalamic nucleus is doing? Subthalamic nucleus is telling, it tells GPI and substantia nigra that you work, right? What GPI and substantia nigra they are telling? They are telling thalamus not to work, right? So it is the normal pathway is that subthalamic nucleus, right? The subthalamic nucleus is inhibited, it is stopped, because if GP is active, so it is stopping subthalamic nucleus that you don't speak. When they don't speak, right? When they don't speak, so this GPI and substantia nigra, they are under the control of striatum, right? They were under the control of striatum. So striatum was telling them what? Striatum was telling them that GP internus, SNR, you don't work, they are not working, so thalamus can work. But now this striatum is telling, so from both the sides, right? GPI and substantia nigra, they were kept under control. Now what happens? Red. Striatum tells GPE, right? Striatum inhibits GPE. So this is negative. You don't work. So if this GPE is not working, so then now there is no one at substantia nigra, subthalamic nucleus. There is no one at subthalamic nucleus. No one can tell him no. So subthalamic nucleus comes into power. So he goes and tells positively, yes, you guys start your work, right? You guys start your work. GPI and substantia nigra reticulosa, the work is they tell the thalamus, why to get worried, don't work, relax. Thalamus is now under the control of both of them, and the movement stops. Movement stops, right? So this is the point which is to be taken home, that this subthalamic nucleus, normally what was happening, that this striatum was not telling anything, right? Striatum was not telling anything. The GPE was doing dadagiri and subthalamic nucleus. कि you don't work. So obviously this track was lost. So GPI substantia nigra, right? They were under this control. It was telling you guys don't work. So this was lost. This was lost. So thalamus was working, right? Which substantia nigra you're talking about? Compacta or reticulosa? Right. Achha. So, right, this is how normally works, but this is our indirect path, right? We have not yet talked about it. Now we'll talk about it. So this is right what happens into the indirect pathway. Now the way we talked about this substantia nigra compacta, that it is the dopamine, this is D1, right? It is very logical and easy to understand that what substantia nigra will do into this, right? Because the indirect pathway is to stop. So which receptor will it be working on? It has to be D2, right? It is the same dopamine, but this time it is D2. We talked about it that D1 is for direct and D2 was for indirect. Do you remember it? Right? We said that D1 and D2, D1 was for direct pathway, D2 was for indirect pathway, and D1 was stimulatory, D2 was inhibitory. So this question that what substantia nigra compacta does, obviously it would be inhibiting, right? It would be inhibiting. So thus this is the inhibitory effect which will be generated. Now what happens when this compacta goes wrong? See, when the compacta goes wrong in the direct pathway, it leads to bradykinesia. Bradykinesia means slow movement, right? Slow movement, because that finer control is lost, so everything slows down, right? This is the importance of dopamine. And over here, when the movements are to be stopped, and if this is damaged, right? So that means that inhibitory action, which is so powerful, when it is damaged, so this means there is reduction in the amount of inhibition. Something which is to be stopped, that is inhibited. Now everything is managed by other ones, but this substantia nigra compacta is so important that now it will lead to those tremors, right? And we have discussed this, that substantia nigra compacta is for finer controls, right? Finer control. So typically the name of the movie which I saw, that is The Cube, right? Very, very khatarnak movie, and superbly means so scientifically created, means there are more than 41,000 cubes and every cube is like a room and they were trapped, and then how the prime numbers are calculated, and every prime number means every room was given a number, huge numbers, and the prime numbers are to be calculated, and wherever the number which is not prime, that is the room for safe passage and they have to move on to that number. Everywhere there were electromagnetic sensors, there were chemical sensors, there were thermal sensors. So those sensors, they will be firing and they will kill the person. And then one after another, those every character, they start meeting in one room and then there is fight. But one of the character, right? He was brainy, but he was having this problem. So this indicates that, say, those who are suffering from Parkinson's, they'll be having those irregular improper movements because this motor skill is affected, but no way it is like their intelligence is affected, right? So classically, when it comes to Parkinson's, it comes like that, it gives 5 hertz of pill rolling, right? Do remember these keywords: pill rolling tremor, right? Pill rolling tremor. So 5 hertz means 5 times in 1 second. So typically their hands, they will keep on doing like this, right? This is what they do in 1 second, 5 times, as if there is a pill between the hands and they are just ruling, right? This is classically seen in Parkinson's. Okay, so these are the two important loops, right? I'm just removing this because as such we'll be discussing it in Parkinson's, so that flow continues in the normal way. Okay, our next loop is the learning loop, right? Is a learning loop. So today's session, right? Everything is written in the form of keywords. So I really wish that when you practice, try to draw these loops and write them 2-3 times so that it gets fixed into your brain. So you know that exactly what really happens, right? Okay, let's start with learning loop, and for the learning loop, it is dorsolateral dorsolateral prefrontal cortex, right? Prefrontal cortex. Now, in short, we can write it like dorsolateral prefrontal cortex, right? This is how we shall write from this point onwards. It affects one caudate nucleus, but then there is one more nucleus, and this nucleus is nucleus accumbens. Nucleus accumbens, right? Both of them, they will be acting on thalamus. So thus now we know that the importance of nucleus accumbens, thalamus, and then that thalamus will be acting on the cortex. Here, this nucleus accumbens, this is one of the important factor, right? And you know the location of nucleus accumbens, right? If this is the caudate nucleus, right? It was this area. That is the nucleus accumbens. This one is caudate. Okay? And then the other end of the caudate, there was the amygdaloid body. Amygdaloid body was, though it is shown as a part of basal ganglia, but it is part of limbic system. You're right. Right? It is related to emotions. It's a pleasure center. That's why. Learning is always a pleasure. If you remember at that point, I told you about this, right? I think you are missing it. This is reward and pleasure center. That's the reason that when you actually, because see, our brain works on the principle of reward. So that's why whenever you learn anything with super interest, right, as if it's a sort of pleasure, you'll be able to remember it for a longer duration, right? So, and another thing is that this is not like mathematics that 2 means only 2. These nuclei, they carry multiple functions, right? So learning is exactly associated with reward due to this particular reason, right? That's why it is always said, not only that, you'll also find that when we'll be learning about only the learning pathways, this is a learning loop which is related to basal ganglia, right? The moment will be involving the red nucleus, right? We have not yet talked about the red nucleus, but today I'll show you the red nucleus also. That is also a component of motor coordination. So at that point, we can't say, you were telling that motor coordination was associated with this substantia nigra from where this gentleman has come, right? So that's how things are. Right? It is not so that it carries only one function. And this part was already mentioned, that learning and the reward, they both are always going hand in hand. Plus the emotions part. That's what we are taking now. Next, this is what is called as the limbic loop. Okay? Limbic loop. Now, limbic loop, simply all the emotions which is represented on the face, right? On the face. There is one very good serial, I think White Collar. Yes, White Collar. Right? White Collar. A very nice series, and in that they have shown the micro movement that what really happens when the person is telling something genuinely, or when he is not sure, and how the facial expressions, plus when the person is lying, where is the imbalance between right and left part of the body, right? That was discussed at a very fine line. Then I came across one interesting book. So anyway, we'll deviate too much in that. But anyway, the point was that, see, limbic loop, right? Just now I told you about that caudate nucleus. Again, the nucleus accumbens is coming, right? Nucleus accumbens, because this is also important for the expressions. Why? Emotions, right? Pleasure, learning. This is the reason. If the nucleus accumbens is not there, there won't be any aha factor, right? Sometimes when we learn something, we feel, array, wow, right? Definitely you will feel that thing when today you'll be talking about that absent swallow MRI sign, right? You'll really feel good. So here is our caudate nucleus accumbens, right? And that's the, say, temporal cortex, right? Temporal cortex, that will feed into it. Then we have got the amygdaloid body, right? Amygdaloid body, again emotions, right? Amygdaloid body, right? That will feed to them. Then from the cingulate gyrus, right? That from the cingulate cortex, right? We just say cortex, everything included. Cingulate cortex, then hippocampus, all are associated with various emotions. Everyone feeds to nucleus accumbens and the caudate nucleus, right? Then they will go to big boss thalamus, right? Okay, this is what is to be done, right? And it is this thalamus which will then go all the way to this orbitofrontal cortex, right? Orbitofrontal cortex. And from there it starts, because this is the area where the face is represented. Face. So every part, every muscle of the face is having huge innervation, right? Very properly. That's why you can generate so many expressions on your face, right? So this is so systematically designed, right? All of them. And then the thalamus, the tract which is associated with the emotions part, that only goes to orbitofrontal cortex, and things are represented onto the face, right? So this is the third loop, right? And the fourth loop which we need to talk is, this is what is called as the oculomotor loop. Now see, in this oculomotor, sorry, sorry, this oculomotor, so sorry, 2 minutes, I'll write and then I'll explain. So we were talking about oculomotor loop. So types of eye movement. So one is smooth pursuit. Smooth pursuit means very slow tracking, right? Say for example, if a car is going, then we smoothly follow it, right? So this is a slow tracking. Slow tracking. Saccade. Saccade is rapid eye movement. Say for example, you are watching a tennis match, right? So ball goes from left to right to left to right. Or if you are playing, say, table tennis, right? It's a very high speed game. So obviously when the ball is moving, you will be going over there, and then the movement of the eye would be very rapid. So this is the major difference between both. This is smooth and this saccade is a rapid eye movement. Now it's not only rapid like just going right to left and left to right. No, it is like point of fixation. Do remember this point of fixation. Point of fixation. So saccade is, this is one point, and then immediately your eyes they move to next point, and that is the second point of fixation. So from one point to second point of fixation, right? Then I stop that at point. So there. Now this is normally we don't do, right? We don't do. But if it is to be done, we can do that, right? So this saccade is to be under our control, and you will say, okay, yes, that is fine, right? It is completely okay, right? Third type of movement is vergence, right? This means, say normally these are our eyeballs, right? They move like right, left, right, left. They move in the same direction, right? So normally they move in same direction. But for certain movements, this thing will vary. When they move in same direction, so that is called as the conjugated movement. Conjugated movement, right? This is when both eyeballs going on one side and both eyeball going on other side, same direction, right? So that is conjugated. But when they are going into different direction, so that thing is what is called as the disconjugate movement. Disconjugate, right? Disconjugate. You want to see that, right? Very easy. So both eyes, different direction. So for example, you take a pencil, right? You take a pencil and then you start, let it come near you, and you try to focus on the tip. You'll find that your eyeballs, right? They will be going towards they will be looking towards the pencil, right? So they both will converge, right? So this is what is called as the convergence. So that's the eyeball and they will be looking like this. This is convergence. And when you watch at a distance, right? So they will be like divergence. Right? So that is vergence, that is convergence, and the divergence. And the fourth one, which is also called as the VOR, right? VOR is, say these are the movements which we do, but we at times don't realize, okay, yeah, really this is something what is happening. This is vestibulo ocular reflex, or the movement is called as the VOR. What VOR is, say I'm watching towards you, right? I'm watching towards you. As I start moving my head, but still I'm watching towards you. My head is almost on this side, but still I'm watching towards you. And as I move it on the opposite side, still I'm watching towards you. This is what is called as the vestibular reflex. It means what? You are stabilizing gaze. You stabilize gaze. Gaze means nazar, vision, right? You stabilize gaze during head movement, right? During head movement. Apple has recently put one very interesting thing into their those AirPods. So stabilizing gaze, that is during head movement, the extraocular muscles, they will start working in such a way to compensate that eye movement. Because see, otherwise when the head is moving, so even eyeballs are moving, but immediately this side of extraocular muscles, they will pull and they will pull and they will start watching. This side of ocular muscles, right side, right, they will relax so that eye goes on this side. So here the extraocular muscles, they come into picture. Okay? So they are stimulated or they are inhibited, contract or they relax to compensate that eye is moving. The physical eye is moving in other direction, so let's adjust it. This is vestibulo-ocular reflex. Right? So now, I said the thing what I was talking about is now in those AirPods Pro, right? So when you apply them, and if you move your head like right to left, the even the principle is that is the spatial audio, right? Spatial audio. In spatial audio, you won't be able to figure out whether the instrument is playing in your right side or left side. It feels like as if the whole thing, the music is getting played into your head. The same is the principle of the Bose system, right? The principles are like, even you have got one, two, the bar over here and the satellite speakers. But if the chopper is moving from here to here, you will actually feel like that, yes, it is passing in front of you as if there are speakers, right? Because they will be generating those crest and trough in such a way that in between they meet and the artificial sound is getting generated. So at times you'll feel like, is there a speaker over there, right? So these are like same principles. Okay, so now we move on to the oculomotor loop. Oculomotor nerve, right? The cranial nerve, number 3. The whole game starts with eye, right? So over here, the game would start with eye. Eye will feed to our visual cortex, right? It will feed to visual cortex. Now, there is visual cortex, but there are two other visual cortex, and that visual cortex, they are frontal and the parietal eye fields. They are called as the frontal and parietal eye fields, and that's why over here we'll tell it that this is a parietal visual cortex, right? And they feed frontal eye field, frontal eye field, and the parietal eye field, parietal eye field, right? Parietal eye field. Now what they both will be doing, they will be feeding to, and you know this, gentleman, superior colliculus. Superior colliculus, right? Now it happens like most of the time, this superior colliculus is inhibited, because what this superior colliculus will do, say I saw something interesting, right? Eyes, right? So the eyes, if they see something interesting, yeah, this is interesting, right? I know that what you are thinking, right? But the thing is, yeah, brain works on that principle. So this is parietal eye field. Now it, so parietal eye field, parietal visual cortex will say, chalo, chalo, right? Move your eyes towards that interesting person, right? So from frontal eye field, parietal eye field, they will fire superior colliculus, go, right? Superior colliculus will immediately inform brainstem, right? And brainstem, from brainstem, who is coming out? 3, 4, 6, right? Cranial nucleus. So this is oculomotor, trochlear, and abducens, right? And all of them, they do simply, they supply all those extra ocular muscles, right? This is like lateral rectus, this is superior oblique, and rest all the muscles, they are by the third one. Because third one is supplying more muscles, that's why the name is given as the oculomotor loop. It's not so that in oculomotor loop only the oculomotor is involved. No, even others are involved. But because oculomotor is playing a major role, trochlear and abducens, so they're supplying just one muscle. This is to supplying rest of all, that is superior rectus, inferior rectus, lateral rectus has arrived, right? And the medial rectus, superior oblique has there, and inferior oblique and levator palpebrae superioris, right? All these muscles, they are by oculomotor. Okay? So this is normal, but no, we don't do it every time, right? We don't do it every time because there is again substantia nigra. This is the substantia nigra. So let's change the color. So that is substantia nigra, which is preventing, right? Most of the time, substantia nigra, this will prevent, right? It will keep the superior colliculus in a inhibited state. Inhibited state. So this prevents that unwanted saccadic movement, right? So thus unwanted saccadic movement is avoided. But when anything goes wrong to substantia nigra, that control is lost. When that control is lost, right, immediately eyes will keep on moving like this. And this would be one of the important sign, right? That is what is called as the saccadic. Okay, so okay, so right, we talked about brain till we were till brainstem. So see, when the eye movement is needed, right? So when eye movement, right? Now this is what when we really want the eye movement. So here the same dorsolateral, right? Dorsolateral prefrontal cortex that comes into picture, right? It will send message to caudate, right? Caudate will be talking to substantia nigra, right? This time it is reticulosa, right? This substantia nigra, reticulosa, that will be talking to superior colliculus, right? And then that superior colliculus will be talking to basal ganglia. Sorry, brainstem. Basal ganglia, brainstem. And from brainstem, we saw this 3, 4, 6, and it continues, right? When eye movement is needed, this dorsolateral prefrontal cortex would tell to caudate. Okay, tell this substantia nigra, okay, boss, stop. Don't stop this superior colliculus because things are so interesting that we have to watch, right? This time we want deliberate saccados. So substantia nigra is told that you don't interfere with superior colliculus. Superior colliculus is now happy. We'll send the message to brainstem. Kare jao jao jao, right? 3, 4, 5. Let them work. Let them do, and let them see. So that's what we see, right? This is deliberately when it is done, and this is called as the disinhibition of superior colliculus, right? That means colliculus, superior colliculus, which was previously inhibited, now it is not inhibited, so it is allowed to send the information to brainstem, and then that movement occurs, right? This is normal when we want, when eye movement is wanted, right? Let's move on to now our Parkinson's disease. I picked this thing deliberately because it is pretty common. And if you know as a doctor, as you know that, okay, these are the early signs, right? Some of the signs, they are so early. And then there is one condition, what is called as the juvenile Parkinson's. Juvenile, normally it is said that Parkinson's, so that occurs after the age of 65, 17, late age. No, but juvenile, it can start much early, 20 to 40, right? So early. And no one is going to straight away advise to that person that chalo go for high resolution 3 Tesla MRI, right? No one is going to do that. And initially, even if it is done, you might not be able to diagnose your patient with that. But then there would be some sign symptoms which will be so typical, right? That's what we want to discuss it, because this will give us a very important idea that how it can be diagnosed clinically, because there is nothing like a lab test which will tell you, okay, this person has got the Parkinson's. No, right? It is purely neurology. In neurology, many of the things, they are based on the principles of diagnosis, that is clinical diagnosis, your skill sets, your ability to interpret, and then radiology would enter, right? This is one of the best example that once you know that what you want, you go to specific that area, you watch it, and you come to a conclusion. Okay. So starting with Parkinson's, and all we need to understand, one is the direct and second is indirect pathway. Sorry. Direct pathway and the indirect pathway. Direct pathway, when it is involved, when it is faulty, it will lead to bradykinesia. Bradykinesia means slow movement, right? Slow movement. Indirect, when it is affected, so that will lead to tremors. Those tremors, they are classical. They are classical 5 hertz pill rolling movement. Pill rolling movement. Also, that substantia nigra compacta, it controls very fine movement, right? Very fine. So it means one by one how the muscles are supposed to contract and relax. When that thing goes away, the third cardinal sign, these are all called as the cardinal sign. Cardinal sign means these are the signs which develops, and definitely they are present. These are the cardinal signs, vital signs. So first is bradykinesia, second is tremors, the third cardinal sign is rigidity. When we'll be discussing clinical part of neurology, right? That is a clinical understanding of the neurology. At that point, we'll talk in depth about the rigidity, that is various types. One is like clasp knife. Just giving the example, clasp knife. Clasp knife rigidity. This is like Rampuri Chakku, right? So how it opens, thak, right? So in that patient, normally patients, they will remain into this flex condition. So when you try to straighten their hand, this Rampuri Chakku is opening and then suddenly straight, right? This is how we used to remember. The sophisticated name is clasp knife, but otherwise, when we'll be discussing, I'll actually write it like Ram Puri Chakku, because that way it is easy to remember, right? Okay. Over here, the rigidity would be cog wheel rigidity. Cog wheel is that paya, right? The wheel of classical wheel of that tanga, right? The tuck, 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 tuck. So there is rigidity, no rigidity, rigidity, no rigidity, rigidity, no rigidity. So when you try to, patient will normally remain into flex condition, flex posture, right? When you try to straighten his hand, this would be the appearance, right? See again, right? It would be like, and you are doing this thing under pressure, right? You are trying to straighten. So it would be like this. So that is what is called as the cogwheel rigidity. So these are 3 important cardinal signs. So basically, if the definition, if it is asked, right? See, Parkinson's, there is a difference between Parkinson syndrome, right? There is a difference between Parkinson syndrome and the Parkinson's disease. Parkinson's syndrome means it will be comprising of a big list in which the sign symptoms will be very similar to that of Parkinson's disease. But Parkinson's disease, so one would be the Parkinson's disease. What could else be? Maybe say because of ischemia, right? Because of ischemia and the area is damaged, right? There is another what is called as the Lewy body, Lewy body dementia. All these, right? There is a big list. So all these are giving symptoms which are quite similar. But Parkinson's, it is like in 80% of the cases of Parkinson's syndrome, Parkinson's disease is the cause, right? So that's the thing. So that is what was to be clarified. So this is Parkinson's disease, neurodegenerative, right? Neurodegenerative. Let's be very specific that what exactly is happening. Neurodegenerative. There is one. It is not sudden. It is progressive, right? It is progressive. My only intention for of today's session from this point onward is that say at times if it is said कि चलो boss write down the note on Parkinson's disease and we start writing, right? Must everything we write. But when it comes to clinics, things are different. So there every word would be important. That if you remember that yes, this is progressive. It means history would be long, right? History would be long. This is progressive degeneration, right? Progressive degeneration. So if the patient has come to you before about say 6 months and then patient thought कि चलो यार ये doctor तो बोलते हैं let's not go for the treatment, take vitamin tablets. Yeah, I'm telling you this thing as a true case, a real case. After 6 months or after 8 months, when they come, conditions are deteriorated. Still, the time keeps on rolling. That let's talk to this doctor, let's talk to that doctor, right? And but time is important because this is progressive degeneration. Progressive degeneration of what? Progressive degeneration of dopaminergic. Dopaminergic means those neurons which are releasing dopamine. So dopaminergic neurons. And these dopaminergic neurons are where? They are in, very right, substantia nigra, right? So dopaminergic neurons in substantia nigra, they are progressively getting degenerated. That is what is called as the Parkinson's disease, right? And we talked about their cardinal signs, right? One was the bradykinesia, right? Bradykinesia. Second was the pill rolling, right? Pill rolling tremor, and it would be 3 to 5 hertz. Now we can't measure that whether it is 3 hertz or 5 hertz, but you know the typical this, right? This is the movement. This is classically this type of movement. So if you calculate 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and 3 seconds have passed, so roughly about it is 3 to 5, right? And the rigidity is cogwheel, right? Cogwheel. So this is the Parkinson disease, which is so common. Classical, elderly, right? It is seen in elderly. So common it is that in this is like 2 to 4%, but depending upon the country. But still 2 to 4% of the population over 65 years, they suffer from this. It's a big thing. It's a big thing, right? The variant of it is what is called as the juvenile Parkinson's disease. So from this point onwards, we'll just write PD, right? So it is what is called as juvenile Parkinson's disease. And in this, it is 20 to 40 years, right? One of my student, right? Just a mail came and I told him that you go for this, and yeah, he turned out to be the juvenile case of Parkinson's disease, right? Now what I'm about to write, right? Don't be panicky with that. In 90% of the cases, it is sporadic. In only about 10-15% of cases, you will find that there is family history. So in case if there is no family history, don't rule out कि यार family history नहीं है, this cannot be known. In 90% of the cases, it is without any family history, right? It happens. It happens. So these are like, say, something basic about Parkinson's. When you talk about clinical representations, right? Clinical presentation, bradykinesia, we talked about rigidity, cogwheel rigidity, right? We talked about, right? That is cogwheel rigidity. This is bradykinesia, everything slows down. All because of substantia nigra. All these things, they are due to substantia nigra. Because see, we talked about bradykinesia, direct pathway, rigidity, right? It is because it is giving that fine control and it happens. Now what I'm about to tell you about is, say, this is bradykinesia, rigidity and the tremor, right? And this is, in this I'm adding one more, resting tremor. Resting tremor. It means it is not necessary that them when they work, that tremor occurs. No, it can occur as such 5 hertz and pill ruling. Fourth, gait. Gait is how they walk, right? How they walk. This is again very typical, right? There would be shuffling. Shuffling is moving from right to left, right? Right to left. Because the problem is that at a later stage, they won't be able to balance. The balance will go. So they would try to shuffle from right to left to balance. And then there would be, you will also notice a short stoppage. Short stoppage. This is in the initial cases. One more feature which you will be noticing, that on road, if you see such person, right, the arm swing, right, there would be decreased arm swing. Now these are all very initial symptoms. It happens in very initial stages. Yes. One point I missed to tell you. When they write, right, when they write, you will find that as they start writing, and I'll show you that it is called as the micrographia. Right? When I was learning this graphology, that is study of handwriting and how you can find out the characteristics of a person from his handwriting, this thing was mentioned. That sometimes it is not only the characteristic, you can even figure out the diseases. And one of the thing is micrographia. I'll show you how it happens. You tell that person to write anything, right? And he starts writing like this. Is matlab literally like Kida Makoda, right? They will be writing so small, so small, so small, because the hand movement is shaky. They don't want to move the hands much, right? So this is like, at times it is completely illegible, very small handwriting, right? Very small handwriting. And handwriting is a very higher order, right? Their signature would change. Signature would change. So when it is found that okay, bank is rejecting the checks written by them, though they have written it, right? Because when the hand is shaky, so it looks like someone is trying to fake that signature, right? Because in the bank, when the original signature he must have done about 10, 12, 20 years back, and now the new signature, no way they will be matching. They'll be totally different, right? This is the micrographia and the change in the signature. You watch that person, you keep watching that person's face. This is called as the hypomimia. Mimia is mimicry, right? When you give all various sorts of expressions, here they'll be like a flat face, right? Flat face. They won't like to express, because that expression, once again, the limbic system is involved, right? So that will not be. So even it is involved, there would be less eye blinking, See, all the loops are involved, right? See, interestingly, all the loops are getting involved. So these are some other sign symptoms. Now, as things progress, right, there would be when the when rest of the systems they start getting involved. So that is autonomic systems, right? So there would be postural instability, right? Postural instability. And for the autonomic nervous system, when it is involved, so then then complete line, there would be constipation, right? There would be constipation. Then even the smell is affected, sleep is affected, sleep becomes disturbed sleep, right? Sleep is extremely disturbed. Then all those hallucinations, fatigue, right? Hallucinations, they start talking, right? Hallucinations, fatigue. Then one common word which is said to them is somnolence. Somnolence. Somnolence means for no reason they are irritated, right? So they will be drowsy. They would like to sleep for longer duration, late, right? Late, they wake up late. They are irritable. They'll constantly be complaining of, say, continuous headaches, right? A very typical picture. So this is collectively called as they sleep more, right? They sleep more. This is classical picture of say Parkinson's, right? Not all the things they are present together, but yes, they can be. Now we are about to learn not only the pathology part, but the radiology part, and now everything is whatever you have learned till this point, let's combine all of them. Just one topic, and then we start combining it. The pathology. In pathology, I would like you to know about Lewy body. Lewy body. This Lewy body is basically it is a protein, right? You want to see? Let me. I'll have a picture. First, let's put it. First, Lewy body. Previously, it was thought of that this is like it has to be present in Parkinson's. Okay. But before we come to that point, Lewy body is present in everyone. Present in everyone. It has got a protective phenomena. Basically, it is protein, right? But when there is abnormal aggregation of this protein, abnormal aggregation, then it is a matter of trouble. So this is abnormal aggregation of protein, and this is protein inside inside the nerve cells, right? So inside the nerve cells. This is how it would look like microscopically. Here it is, right? These are Lewy bodies. Now, if you just before few minutes we talked about juvenile Parkinson's disease, right? Juvenile Parkinson's disease. That is something which is occurring in young age, 20 to 40 years, right? In elderly, when you examine, yes, you will find this Lewy bodies. But in juvenile Parkinson's disease, this is very interesting. There is no possibility. There is no possibility of Lewy bodies. No, it cannot occur. Reason? This JPD, that is juvenile Parkinson's disease, that occurs due to PARK2, right? PARK2. This is the gene defect. This PARK2 gene defect. Now, this PARK2 gene defect. Normally, PARK2 gene defect means normally PARK2 gene is for encoding enzymes of ubiquitin ligase 3, right? So this is ubiquitin ligase 3. This is nothing but this is one enzyme, right? So let's see. This is normal, right? This is normal. So this enzyme ubiquitin, ubiquitin, right? Should I write it bit proper? Ubiquitin ligase 3. So this is the enzyme, and that will lead to formation of alpha synuclein. This is alpha synuclein, right? So this alpha synuclein, this is the main component of Lewy body. So if the gene is defective, right? If the gene is defective, now you know it, gene is defective, so it means this enzyme won't be produced. If enzyme is not produced, so then this alpha synuclein will not be produced. So there is no possibility of development of Lewy body, right? And because this is the Lewy body. So that's the reason in juvenile disease, right? It is not present. But otherwise, this is good. This is in when it is evenly distributed, when it is normal, so it is like having a protective function. And one more important function of this Lewy body is, right, because that will be Lewy body, or we just write LB, the protective function. One is the protective, right? And second function is that this is presynaptic protein, right? It is a presynaptic protein. So that's why it has got a very important role. But only when there is abnormal accumulation, trouble starts. Now for the diagnosis, right? One, no lab test. There are no lab tests. In radiology, there are, right, which can give very, very precise diagnosis. First, we start with the basic. Either person goes for CT scan, right? He goes for CT scan. And on CT, what is really seen is that his cerebral volume, that is decreased. So there is loss of cerebral volume, right? Cerebral volume loss. And you'll find that gyri, they are shallow, sulcis, they are deep, right? Volume loss. You can go for ultrasonography, ultrasound of skull. Yeah, this is a very special thing. It is called as the B mode transcranial ultrasound, right? So B mode transcranial ultrasonography, you go for it, and in that you watch for substantia nigra, right? Substantia nigra. Well, कहने को तो it is quite okay, right? And yes, you will be finding that increased echogenicity. But this is system dependent, or the machine dependent, system dependent. Your system, your machine, your computer, your analyzer, that should be of very good quality. Then and then you can really say decipher this. What is more promising? Well, more promising is MRI, right? This is in fact most promising. And I'll show you the images also. This is the most promising diagnostic tool. So what would it show? We'll start with a bird, right? The study of bird, it is called as the ornithology, right? So we don't have to study the ornithology, right? It is study of birds. But we'll come with one bird, and that bird is, I'll put the image. This bird is called as the barn swallow, right? A very high speed bird, right? Flies at a tremendous pace. This bird is called as the barn swallow. And we are interested in tail of this lovely bird. So focus only on the tail, right? And this is what we'll be using in MRI. Say as such, when we'll study the radiology, many of the signs they are based on fruits, then things to eat, then these birds, right? All on or on some cartoons, right? Very interesting signs. Acha. What you will see. This is called as swallow, right? Name of this bird is swallow. So this is the swallow's tail, right? This is swallow's tail. There are some structures which would be appearing like this. There'll be some structures which will be appearing like this. When they don't appear like this, so then we say that this appearance is lost. So when that structure, it looks like this, so this is called as the swallow's tail sign. And if the structure looks like this, so we say that yes, it is good, it is positive swallow tail sign. That means this is good thing, this is normal thing, right? And everything is good, all is well, right? So let's see how we say about it, and then we'll talk about the abnormalities. Okay. Now see, watch this area, right? It looks like swallow's tail, right? Your first impression would be, hey, right? This. Now I'll zoom it. Right? This is positive or present swallow's tail. Right? Positive swallow's tail. Now, if you want to see that how it really looks like in abnormal cases, watch the opposite side, and then there will be the aha factor. Oh yes, the whole thing is like this. This is normal. This one is abnormal. This is a patient of Parkinson's. What you are watching is substantia nigra. And what you are watching in between, the loss, right? That is where those nigrosomes, they are lost. And that's the reason it gives this appearance, right? This is abnormal. That is absent swallow's tail sign. That is absent swallow's tail sign, right? It is absent. Now, if you really want to do this thing, so it's not so that it will appear immediately like this, but what you need to do is you need to go for high res, high resolution, right? High resolution MRI. In that, you need to go for 3D. In that, you need to go for this weighted imaging, selected weighted imaging, right? And the high resolution machine, so that is the 3 Tesla, right? 3 Tesla machine. Then you see this, right? This shape is telling that we are passing through the midbrain. This is a midbrain section. Midbrain section. Right? This is how it looks like. So why it happens? Technically, when sorry, technically when it is asked that how the things would look like, what we'll say is that on T1, right? In MRI there are T1 weighted and T2 weighted. Over here it is the T2 weighted, which is classical, right? On T1 there would be increased intensity. There would be hyper intensity. Hyper intensity means it would look white. It will look white. Hyper intensity of the substantia nigra, right? Substantia nigra and red nucleus. So where is this red nucleus, right? Where is this? Let's see one MRI section, right? And we see the red nucleus in that. Because red nucleus is the largest. It's named like red nucleus. Right? Yeah, very nice section. Okay. Skip it on this side. Flatten, yes. See, this is the section which is again through midbrain, right? See, you can see the eyeballs and then this classical shape, this one, right? It is midbrain, right? So just the first look and then you say that this is midbrain, and in this midbrain, we identify certain structures, and those structures are one, our red nucleus, right? That's what we talked about. This one is the red nucleus. Right? The red nucleus. Then this big one over here, this one, subthalamic nucleus, right? The STN. Then very small, right? This one, right? Typical shape, that mammillary body. Mammillary body. So the idea is that when you look at this red nucleus, right? When you look at this red nucleus, that red nucleus, it is, if you dissect it, normally it looks pink, right? It is because of the iron content. Because of iron content. So if this content is more, so that thing would look as the hyperintense one, right? Hyperintense. So red nucleus is one of the important component for motor coordination. Motor coordination, right? At the level of the brainstem, right? So we talked about these signs. Now, apart from this, in T2, how it looks like, right? We talked about, I think, T1, right? Yeah, we talked about that, how it looks like in T1. In T2, its appearance is just one liner, right? Absent swallow tail, right? This is absent swallow tail. One. And the second is, see the substantia nigra and the red nucleus, right? Both of them, they are affected. So substantia nigra and red nucleus. So there would be, you'll find a signal drop. So you'll find the signal drop. This is so promising, right? Because this is a typical appearance. And why it happens like that, this is the normal appearance, right? Substantia nigra, the whole thing. But over here, the nigrosomes are there. Nigrosomes are there. But when this place goes like this, so it means they are now, they have stopped working and you lose that particular sign, right? Very typical. Now, anything else apart from this, and that is where comes the nuclear medicine. Nuclear medicine. And in nuclear medicine, at times we know that yes, this is getting done, but the names are different, right? Where this in substantia nigra, right? This one would be the substantia nigra. That's what is, right? Because this is part of midbrain. Achha. Now the nuclear medicine. No, at this level, so we are just watching this for the red nucleus. In MRI, here it is. This one, this entire portion. This is the substantia nigra. Whole thing, right? This is the classical appearance of substantia nigra. This is the classical appearance, right? And when it goes like this one, so that is abnormal. This is normal. This is abnormal. Okay. So in nuclear medicine, two things. One, what is called as the single photon emission computerized tomography and the positron emission tomography. Both of them, they are used. In SPACT, this is what is called as the I1 to 123 ioflupane, right? The common name is that DOTA scan, right? Or the DAT scan. DAT scan. So in this, so we know that this dopamine is presynaptic, right? So this is when it is injected, so it is normally picked up, right? It is normally picked up by dopamine presynaptic transporters. So when it is like this, right? So you will be able to see that. But when in Parkinson's, right, in Parkinson's disease, this is not present, right? So this normal pickup would not be present. So there would be what is called as the loss of coma shaped uptake, right? Comma shaped uptake in striatum. So when it looks like this, you find out that it is the putamen. Things are not picked up by putamen. Then gradually from coma shaped pickup, this is normal, it will become oval. When it becomes oval, that means even the caudate is affected. So later, caudate affected, right? So important. Regarding the treatment, well, we said that one, you need to give levodopa, right? No option but to give it, right? Because all the regimens, they will be based on that. And the moment you give levodopa, there would be decreased bradykinesia, right? There would be decreased tremors, and things will be pretty effective, right? You can also give, this is one. Then for this say to prevent or the say dopamine receptor agonist, that is those who are supporting the dopamine receptors, right? Like bromocriptine, very common, right? Bromocriptine. So that can be used. Third is say we have few chemicals which will break the dopamine. So in the synapse, right? In the synapse, when the dopamine is released, this dopamine is attacked by MAO, right? Monoamine oxidase. Right? So this monoamine oxidase, in fact, to be very specific, it would be type B, right? Monoamine oxidase type B, right? MAO B. So they will be attacked. They will be attacking this dopamine to remove them. What if we use something who will inhibit them? So let's inhibit them. So they are called as the MAO inhibitors, right? They are called as the MAO inhibitors. Inhibitors, right? MAO inhibitors. And they are pretty well tolerated, and because the dopamine will not be destroyed, so it will be continuing its life cycle for more time. So that way it would be more effective, right? There are other symptomatic drugs, so which you use as per the requirement of the patient, right? Say for example, amantadine, right? That is like a short-lived drug, but it is used, amantadine. But say it is like a symptomatic relief. It will give the relief from say bradykinesia, etc. But nothing from the point of view of the treatment. Right? So bradykinesia is decreased, tremors are decreased, symptomatic relief. For the treatment part, say this is medicine. Surgery will come into picture only when the medicines, they are not effective. So many things like say always they start with deep brain stimulation. Deep brain stimulation, DBS. And in deep brain stimulation, actually this is the skull, so the holes are created and then the probes, they are inserted in, and then the current is passed, right? This is deep brain stimulation. Anything, if it is put into brain, yes, it carries the risk, right? But that's the reason that it is to be used only when the medicines are totally refractory. They are not affecting at all. Otherwise, for rest of the things, say physiotherapy, right? Physiotherapy, speech therapy would be very important. Speech therapy, right? They are of good importance. So this was about our all 4 loops of basal ganglia and something about the Parkinson's, right? Thank you so much for your patience, and do revise. This thing would be very helpful to you as you will be reaching your clinics and the final MBBS, right? So thanks a lot, saving this file and putting into our folder. See you next time. Bye bye.